Good afternoon, everyone. I'm Kristen Waller with the American Heart Association. I'm the Quality and Systems Improvement Director for the state of Arkansas. And we also have Zach George with the Joint Commission with us here today as well. The agenda for today, I'm going to jump right in with the Get With the Guidelines coronary artery disease demo. We will discuss receiving PCI centers and also referring or non-PCI centers. Zach will cover the AHA Joint Commission cardiac certification, and then we'll follow that with a Q&A session. Everyone should be on mute right now. Once we are done with both of our presentations, we'll tell you how to come off mute, and you can ask questions for the Get With the Guidelines demo or for the cardiac certification. Just a little bit of background about myself. For those of you that wear multiple hats in your hospital, you probably know me from Get With the Guidelines Stroke, since the majority of the state does participate with Get With the Guidelines Stroke. But my background, I was a night nurse in ICU. I started out 15 years ago, and I moved to interventional radiology and then throughout the cardiac service line and ended as a STEMI chest pain coordinator. Okay, and I see where someone is having trouble with audio. I'm going to pause for just a moment. Let me escape this so that they can see the number to call. I apologize. Hang on just a second. I'm going to try to pull it up, and it's not showing that. Okay. Let me stop sharing my screen so I can get you that number. The number to dial, and now I'm not seeing it. I'm so sorry. This will be recorded. If somebody can see the number to call, could possibly type it in the Sandy, if you could look at the calendar invite, or no, I'm sorry, I didn't send a calendar invite, but the email that I sent a couple of weeks ago from Kristen Waller, the number to dial should be in that email as well. Okay, let me share my screen again. Get that presentation pulled back up. So as a STEMI chest pain coordinator, I abstracted for registries, worked on accreditation, public education and events, EMS, and referral center outreach, and then floated wherever I was needed within the service line, including finding a bed, because as a STEMI receiving center, we always have a bed. And now we're going to hop right into the demo. So Get With the Guidelines CAD is on a new platform, and it has a different look if you participate in Get With the Guidelines Stroke. Stroke is in the PMT, the Patient Management Tool, and it does look a little different. So CAD has an updated look to it. And what I want to do today is show you the fields that are required. The fields that are required to enter a patient into Get With the Guidelines CAD. We are have a lean data field set requirement. And so I just want to go through that fairly quickly and show you how easily a patient could be added to Get With the Guidelines CAD. You could also, as a STEMI coordinator, take an iPad to the cath lab, to the ER, and start entering this information as well. So today we're just going to do, I'm just going to create a name and a patient ID and add. We'll start with the arrival date, and we're going to do July 1st at 0900, and we're going to submit, and that's going to create us a patient record to enter. We'll select a gender, the date of birth, a zip code, way you can go back and see where you need to focus on public education and outreach. A payment source. When you select race, if you were to select Asian, then it would show more fields. The same with Hawaiian, Pacific Islander. But if you were to select white, then or Black, African American, then the extra fields that you do not need will not populate. The same thing with Hispanic. If we said yes, then it would give us some options. Or if we said no, it's not going to show us the options. We call that the hide show feature. So you're only focused on what you need to enter into the registry. Our next tab is the admin tab. Since this is in the demo, there is a long list of physicians to select from, and it takes a little bit to load. If you have this set for your hospital and the physicians at your facility, then it's going to be a much shorter list to select from, and it will not take that long to load. But the arrival date and time is going to fill from when you first created the patient. The admission date, if you don't know the time, or if you don't know if you want to put the time the ER doctor wrote it or the admitting doctor accepted, or you don't have a time, you can change this to just the date. If this patient was not admitted, you could put here if you're going to transfer them out. If this patient was first seen in the ED, then you select that, and all of your ED fields would open up for when they left the ED physician. Or if we're going to bypass and go straight to the cath lab, then we can select that, and the ED fields will go away. There's no need to look at those. Cardiac diagnosis, this is a STEMI. Is this patient enrolled in a clinical trial during hospitalization? If you say yes, then you can select what kind of clinical trial they're in. If they are not, which is probably most facilities here in the state, then you just select no. Once you roll over to the pre-hospitalization tab, if you select that they're a walk-in, then all of the EMS fields will go away. But if this patient is arriving by ambulance, then you would select ambulance. You could select which agency, which once again, you'll build your list based on the EMS agencies in your area. And then you'll enter a sequence number. Cardiac arrest prior to arrival, you could say yes, and it will give you more fields. If no, then you just select no. Now the pre-hospital time tracker, unless this patient comes in around midnight, then most of the dates are going to be the same, and you can go ahead and select OK to set them all to July 1st. So our EMS first medical contact will say 8/23. We didn't have a non-EMS first medical contact, so we'll just back that out. If there was a non-system reason for delay, like if the patient refused once EMS got there, if they refused transport or treatment, or if the patient needed CPR to be intubated, then you could select that there was a non-system reason for delay. EMS was dispatched at 8:17. They arrived on scene at 8:21. They departed this scene at 8:35. And then they did send a pre-alert at 8:33. And our method of first notification, they transmitted the ECG. If they were to select that this patient was transferred from another facility, then once again, that would open up a box and you could say where the patient, what facility the patient came from. Okay, date and time of the first ECG. We're going to say 8/29. It was obtained prior to arrival by EMS. We didn't have a non-system reason for delay. STEMI equivalent, yes. First ECG. If it was a subsequent ECG, then you could select that and it would open up the field to say when it was first noted positive. We're just going to say the first ECG. And this patient's symptoms started on the same day, and we're going to say 0700. And then we need to collect the heart rate, systolic blood pressure. Do they have heart failure on first medical contact, cardiogenic shock? Are they taking any patients at home? We want to do a creatinine, aspirin within arrival, within 24 hours of arrival, yes. Do they have positive cardio biomarkers in the first 24 hours? That first troponin. Do they have a history of smoking, history of PAD? And then we're going to move on to the hospitalization tab. Was this patient a reperfusion candidate? Yes. Did we give them thrombolytics? No. And it's going to ask for a list of reasons why. For this particular patient, we're just going to say that their door to balloon was expected within 90 minutes. Did we do a PCI? Yes, we did. We can select our interventionalist. And then same here, we did all of this on the same day, so we're going to go ahead and select OK, and it's going to give us the arrival date. So our cath lab activation time, I'm going to say they were activated at 08:34. The patient arrived at 0900. The attending arrived at 08:45. The same with the cath lab arrival team. The first PCI time was 09:20. And then why did we do a PCI? And that was primary PCI for STEMI. Did we have any non-system reasons for delay? There's a list there as well. So the LV was 45, and we obtained it this admission. We didn't do a cabbage. Cholesterol level, LDL was 110. And so that's your hospitalization tab. And next we're going to flip over to the discharge tab. And we're going to say that this patient left on the 3rd at 1300. Now then, this patient is going to go home, but had we said the patient expired, then all of the discharge elements would go away. They would not apply to this patient. Same with if they left AMA, if they went to hospice. So if this patient goes home, then we do need to collect some discharge elements. Comfort measures only, we're going to say no. Did this patient get a referral to cardiac rehab? Yes. And then we want to go through discharge medications. So they were prescribed an ACE. We didn't do an ARB. We did aspirin. It's going to ask what the dose was. So we could say 75 to 100 milligrams every day. Clopidogrel, we're going to say yes. That was RP2Y12. We're given 75 milligrams daily. So for the other ones, we just want to say no, because we chose Plavix. We didn't have to give any other anticoagulants. We did give a beta blocker. We did do a statin, and it wants to know which one. So the medication will open up. You can select from the list, and we'll say Lipitor. Now, based on the dose that I put in, it's going to tell you the statin level of intensity. So if I picked 20 milligrams daily, it's going to tell me that's a moderate level of intensity. And if I picked 40 milligrams or greater, then it's going to say high. And then the new drug class for cholesterol lowering agents, we didn't prescribe that. And so that is it. Those are the only data fields that are collected in Get With The Guidelines CAD. We can get everything that we need from those data fields for Mission Lifeline, for your door-to-balloon times. It's all captured. This is a very lean data set. Now, if your hospital is collecting or wanting to collect additional fields, then you can create those. Each hospital has up to 50 custom fields that they can create. And I'll show you some of the ones that we've created in the demo site. Maybe it's something that your cardiologists are interested in. Maybe it's something at the statewide level that you want to collect and report out on. And so it's just, you can create them where they're drop-down boxes, or where you can put in month, date, and year, or maybe they're check boxes for certain physicians. If you need a numeric value, does it have a decimal point? You can set the parameters there. So there's just several ways to go about that, and each facility would have up to 50. We found that most hospitals only collect, 2 or 3, just a few that they're interested in at the time. And then if you no longer want to collect those, then you can make them inactive. You can turn them off. So I'm just going to save and exit. And my patient is now saved. So we do have a library within Get With The Guidelines CAD, and it has coding instructions, our Mission Lifeline report. It does have a glossary there if you have a question about any portion of the Mission Lifeline report. If you have questions about the measures that we have, that could be found here too. It will let you know. You can click on primary PCI. It gives you a short, brief description of the measure. It tells you who's included in the initial patient population, who is included in the denominator, who is excluded. And then on the right side, it shows which data elements are used for those calculations. So we have that for each of our measures. We also have training videos available as well. And I want to show you operational reports. This is where you would find the Mission Lifeline report. I do not have one available in the demo site, but some of you are probably familiar with the Mission Lifeline report that shows your hospital numbers and compares it to your region, to the state, and to the nation as well. And so for those that participate, they do have a quarterly report and the capability to refresh that. If you needed to go back and make changes, you could do a what we call a real-time refresh and refresh that report if you needed to make changes. Any information that you put in to Get With The Guidelines CAD, you can pull it right back out in a data download in an Excel spreadsheet. And then there's also measure reports. So we're just going to look at July because the patient I just entered was July. We're going to do semi-receiving center achievement measures. If I only wanted to look at one thing, then I could expand that. We do have filter options where we can compare arrival day, we can compare attending physicians, interventional doctors, whatever it is that you want to compare. If you want to benchmark to other PCI centers or other beds close to your size, or even the state. This demo site was set for Virginia, but it would be set for Arkansas. And so we're just going to apply the parameters. And when you see this report, you are able to export the report into a PDF or a PowerPoint slide, or an Excel spreadsheet, just however you want to present those reports to your at your STEMI meetings, your chest pain meetings. And that's loading. And so when you first pull it up, you'll see a bar graph, and then you'll see your numerator and denominators. And this is the demo site, so there aren't very many in July already. But I like to look at all of my graphs next to each other. So I'm just going to graph similar measures on the same bar graph. So it should load. There it goes. So you can look at them. And of course, the patient that we just put in, we did everything right, so it's hitting 100% there. But I also want to look at a patient list, and I want to see which patients are falling into this measure and which ones are falling out. So I can just click right here on the ACE and mark my values, and it's going to create a list of all the patients in the month of July. And then I can look and see which ones were in the denominator and the numerator. So for this particular measure, the ACE, ARB on discharge, it did not apply to our patient. The LV function was 45%, so our patient wouldn't have fallen in here. If this were to be a fallout, we could click on the blue hyperlink and it would open up that patient, and we could go in and look and see, you know, if maybe we missed clicking on the medication or put in a wrong value or something like that. So you just click on the blue hyperlink to do that. And I'm going to switch back over to my slides for just a second because for the referral centers, it's quite a bit easier. So when you're a referral center, we want you to do one of two things. We either want you to give lytics within 30 minutes or we want you to get them in and out the door with the goal being 45 minutes. So there's not just a whole lot that occurs in that 30 minutes or that 45 minutes. So we have a short form for referral centers that will be released on the 20th of this month. And so it does look similar, but when you click that not admitted, transferred out to acute care facility, it eliminates quite a bit of the data elements. So I'm just going to click through this right quick and show you what you would capture. You still want the arrival date and time and that it was a STEMI. And then it's going to ask when the transport arrived to take the patient out, the facility that you transferred the patient to, and who transported them. So it still wants to know about the first EKG and symptom onset, but it's not near as much information as the PCI center has to enter. And then under the hospitalization tab, it wants to know, was the patient a reperfusion candidate? Yes. Did you give thrombolytics? No. And then that's it. If you said yes, that you would put in the date and time for the thrombolytics. And then there's the discharge. You just need to put in the discharge time, and it will automatically, since you selected that you transferred out, it will put in acute care facility. So all of the discharge medications will not apply to this patient because you were getting them in and giving them lytics and getting them to that PCI center, or you were getting them in and out your door. So it is not just a whole lot of information that you have to put in for this patient. We do have a feedback form that is also anticipated to release on July 20th, and it will give you minutes. It will give you date and times that things occurred, but it will also give you minutes like from your symptom onset to PCI time or EMS first medical contact to PCI. It's going to go ahead and calculate those minutes for you. This is not exactly how it will look. This was just the sample that we were shown. So we are very excited about this form. And then that would just leave the coordinator with maybe adding some pre and post pictures and an EKG to that form and getting it out to EMS or the referral centers or to the ER department or even the cath lab. So these are the 2020 Mission Lifeline hospital recognition criteria, the measures for 2019 data, which we will recognize in 2020. So on the left-hand side of the STEMI in the dark gray, you have your STEMI receiving centers, which are those with cath lab, 24/7 cath lab. And on the right side of the STEMI in the light gray, you have your referring center measures. So I will share this with everyone as well, and it's the same for on the right side of this screen in STEMI measures. You do have the option to enter only STEMIs. We do encourage you to enter both STEMI and in STEMIs. You could be recognized for one or the other or both. I send out a quarterly report to let you know what your data is looking like. Our next one will go out in September. We do allow a couple of months for you to get that data in. Although with STEMI data, we do encourage you to put it in as close to real time as possible. And that's why we have Get with the Guidelines CAD formatted where it will work with an iPad if you go directly to the patient's bedside and start entering data. And this is just a very brief look at the Mission Lifeline report. It still has the stacked bar chart, and it has regional trends as well. So this is just a quick look at it. And I'm going to stop sharing my screen for just a moment so that I can pass this over to Zach. And that is my timer to let me know that it is Zach's turn. So let me get that. And we will open this up for questions at the very end, and we'll tell you how to come off mute. And also, we'll have the recording available and slides available as well. So Zach, if you were on the line, I just passed the presenter ball to you. And if you will hit *6 to come off mute. Okay, if everyone will bear with me for just one moment.
Hi, Larissa.
Oh, hey, it's Kristen. I'm using Larissa's WebEx.
Oh, hey, Kristen. I am here.
Okay, great. Do you want to share slides so that you can advance, or do you want me to pull them up and then I'll take control back? And you can tell me when to advance.
Yeah, let's do it that way, just so when you transition back, it's smooth. Yeah.
Okay. All right, hang on just a second, and I will share my screen again. Oh. Okay, can you see your slides?
I sure can.
All right.
Okay.
Well, I'll go on mute, and you just tell me when to advance.
All right. Thanks, Kristen. Well, good morning, everybody. This is an exciting day. The Get with the Guidelines registry, that was a great demo. And I'm excited to be speaking with you all about the collaboration that we have with the American Heart Association in cardiac certification. Can we go to the next slide? In general, you're very familiar with the Joint Commission. We are obviously the prominent hospital accreditor, but more importantly, we've developed over the years over 100 disease-specific certifications, the most prominent being those in stroke, joint replacement, perinatal care, sepsis, but the other big one is the cardiac arena. And again, with all these certifications available to an organization like your own, this is often a very good opportunity to find some efficiencies, but also find some ease to manage the certifications in different service lines. And this is one of the most exciting reasons that we have now collaborated with the American Heart Association. Next slide. In particular, we've taken a look at the programs we offered and have collaborated with the American Heart Association to create 4 disease-specific certifications with the Joint Commission. The first is the Comprehensive Cardiac Center certification. We have 2 Heart Attack Center certifications that we've also created and launched recently, the Primary and the Acute Heart Attack Ready. And we also have an advanced certification in heart failure, and we'll talk about each of these in a moment. Next slide. The primary thing we have tried to design and build with the AHA really is an integrated system of care, very much like we see in the stroke world. And that's why we have identified 2 levels of heart attack center that are very familiar and now are just following the acute, primary, and comprehensive structure. We begin with the first point of access, the STEMI Referring Center. We refer to that as the Acute Heart Attack Ready Hospital. The Primary Heart Attack Center is the STEMI Receiving Center that is able to 24/7 is able to provide the primary PCI procedure to the STEMI patients. The Comprehensive Cardiac Center is also a STEMI Receiving Center, but also has the capability to provide and treat and provide the bypass, the diagnostic cardiac cath, valve repair and replacement, electrophysiology, heart failure, and even cardiac rehab, either on-site or by referral. The important thing is that comprehensive center is not just the STEMI Receiving Center, but also the final destination for all of the service lines within the cardiac arena. Next slide. And next slide. So the first thing I'd like to speak to you about is the Comprehensive Center. Just to clarify a little bit about this program. The Comprehensive Cardiac Center is very much a program that was designed originally by the Joint Commission, but then was merged with the American Heart Association and the American Heart Association's CVCOE, or Cardiovascular Center of Excellence certification. The combination of the 2 programs really involves the expertise and the mission of both companies to drive integration of the care across the cardiovascular spectrum for an individual patient, to really identify high-risk patients and manage the unique conditions that they may encounter during their life as a patient. And at the same time, to be able to coordinate an ongoing proactive improvement process that, again, is collaborative and is integrated for the entire cardio program at that hospital. Next slide. In particular, the domains of care that are included in a comprehensive cardiac center are the management of ischemic heart disease. This is through medical, interventional, and surgical care. And in particular, what we're talking about here are the unstable angina patients, the STEMI and the non-STEMI patients, as well as the PCI and the CABG procedures that may be performed for those patients. Again, we also are looking at cardiac valve disease and how that is managed at the Comprehensive Center. And in particular, we're looking at them to be able to provide replacement and/or repair at that location. The Comprehensive Center is also able to help manage dysrhythmias, including electrophysiology services and outpatient device clinics. Comprehensive Center is also able to provide resuscitation for the cardiac arrest patient, including especially those in-house arrests that may occur, as well as targeted temperature management. Heart failure management, inpatient and outpatient, is another domain that a comprehensive center would be operating successfully in. And at the same time, Cardiac rehabilitation is incorporated in this certification. Whether it be on-site or by referral, the key is that the Comprehensive Cardiac Center is able to ensure that that rehab will take place and is readily available 24/7 in some form. Next slide. We've created a few volume expectations just to give you an idea of the size of the Comprehensive Center. I do want to say that if the volumes are not met, then we do have a second assessment that we're able to perform, and that would involve just looking at nationally audited registry outcomes, and we would just want to see that those exceed the national average. So these are volume requirements or targets, but again, if you are below those, we will look at nationally audited outcomes. So for CABG procedures, we're looking for about 125 a year, and these are all alone or in combination with other procedures. Valve replacement or repair, we're looking for 50 a year. PCIs, 200 a year, and of those, we want to see that at least 36 are primary PCIs for the STEMI patient. One thing I also want to clarify about this comprehensive certification is that there are no prerequisite cardiac certifications, and there also is no prerequisite amount of data that we need to collect when you apply. And we'll talk more about that later in the presentation. The important thing is if a hospital is ready to be a comprehensive cardiac center and they meet the standards, then this is available to them regardless of past certifications or participation in a registry. One thing I wanted to highlight is that there are no interventional cardiologist volume requirements with this program either. This is more about the Comprehensive Cardiac Center and the volumes and the scale to which it operates. Next slide. Now, another key service line that we wanted to really pull out and focus on building a system of care were the heart attack centers, and we have designed 2 of those. Next slide. And next slide. So a few things that we designed with the AHA to really make sure we're able to accomplish with these heart attack certifications is that we're really looking for a program that will help a hospital demonstrate a commitment to a high standard of service and sustainable and continuous improvement. It's also something that helps to organize the teams across the continuum of care and gain a competitive edge in the market. Finally, it could help enhance staff recruitment. It is something that may be recognized by insurers and other third parties, but you also have all the benefits of the American Heart Association and the Get With The Guidelines registry, such as the online community, education, resources, and so on. Next slide. So we'll start with the Primary Heart Attack Center. Again, the Primary Heart Attack Center is a receiving center. And in particular, what we're designating here is a center that is able to provide the primary PCI for STEMI patients 24/7. And this is something that's available for accredited and non-accredited hospitals. In other words, folks that might be accredited by the state, and critical access hospitals, including freestanding emergency departments if they're under a hospital accreditation as a site. Participation in Get With The Guidelines coronary artery disease registry is essential. The program is also offered in a hospital that is designated a smoke-free campus. That is highlighted, but of course that is also accreditation requirement, but we still highlight that. And then finally, the hospital will need to meet the prescribed hospital and provider volume requirements. So let's take a look at those real quick. Next slide. So the Primary Heart Attack Center, again, in order to obtain this designation and this certification, we begin by looking at volumes. And the first thing we'll look at for the hospital is whether or not they're performing a minimum of 150 PCI procedures. So that is less than a comprehensive cardiac center, but still 150 PCI procedures. What we are looking for that is the same as a comprehensive center is that they are hosting 36 primary PCI procedures for STEMI patients, and that's per year. We do also have a caveat for the sake of this volume, and in the event you're below those volumes, either of those, then we do have some additional assessment that we will perform involving the process by which the cardiologists monitor outcomes. We'll take a look at systems of care processes and protocols that are in place in the community, also formal association with larger facilities, and transfer agreements and protocols. Next slide. The other volume requirement that we're looking for is for the actual interventional cardiologists that are performing the primary PCIs. For those folks at this heart attack center, if they are performing primary PCI, we're looking for an individual volume of 50 PCIs per year, with at least 11 being primary PCI procedures. This is something we are able to average over a 2-year period for a cardiologist, for an interventional cardiologist. And I also wanted to point out that the total that an interventional cardiologist performs includes the PCIs they do at your hospital, but also at any other hospital. It really is an individual volume requirement. As we mentioned before, the hospital's primary PCI volume is 36. Regardless of the number of interventional cardiologists they have, they just need to hit 36. The interventional cardiologists themselves, we're looking for 11 primary PCI procedures per year. Next slide. So the acute heart attack ready is more of a referring center. It's a referring center that may or may not provide primary PCI coverage on site. So they could be a purely referring center that receives a patient and stabilizes them, or they might be a center that is able to perform primary PCIs, but they just aren't able to provide that 24/7. And so they do refer a portion of their STEMI patients that arrive. The requirements for this are very similar to PHAC. You need to be accredited or you need to be designated by the state as meeting the conditions of participation for Medicare. You will participate and get with the guidelines CAD registry. And there is no prescribed hospital or provider volumes for the acute heart attack ready certification. And this is to ensure that those small critical access hospitals that are important to this system of care are able to achieve this certification even if they have smaller volumes. And the primary reason there is not a volume requirement is because they aren't performing or required to perform the primary PCIs. Next slide. So in general, these certifications are structured and in alignment with the other 100 plus certifications that we have at the Joint Commission, in particular the stroke certifications. There are 4 key elements. The first is that you're following evidence-based clinical practice guidelines, that performance is being measured, and that it is improving, and that that improvement is proactive rather than reactive as a result of a survey. And finally, the 4th element are the standards that we have developed for disease-specific care certifications. Let's go ahead and go to the next slide. Just to touch on these elements, clinical practice guidelines, again, we just want to ensure evidence-based medicine is being practiced. In the world of cardiology, this is very well established by clinical practice guidelines in science that has been authored by the AHA and the ACC. And these, therefore, are the clinical practice guidelines that we're requiring for the heart attack center certifications. For the Comprehensive Cardiac Center, because of the number of domains involved, that is something where we do leave the identification of clinical practice guidelines. For some areas, such as rehab, we do leave that up to you to identify the science behind your practices and protocols. As far as the performance measures go, because you're working with Get With the Guidelines CAD for the heart attack centers, the measures are standardized through the Get With the Guidelines CAD registry. For the Comprehensive Cardiac Center certification, we are also standardizing measures, but those have not yet been launched. As soon as we have those finalized, we'll distribute those to the field. But again, they are expected to be registry-driven. A big part of the goal there is just to prevent duplicate data collection. For the Advanced Heart Failure Program, which we didn't really talk about, that also goes through Get With the Guidelines Heart Failure Registry. And those measures are actually able to be identified by you as a hospital. Performance improvement planning, we have a template for a performance improvement plan that every disease-specific certification uses. The structure has been effective. It deals with building an interdisciplinary team, with identifying how performance improvement will be managed over time. And it also allows a hospital to proactively identify its own areas of improvement. Nothing is better than something that is developed by a hospital itself, and based on the familiarity of the challenges that they face that only they have. So it is with this performance improvement template that we ensure the creation of that performance improvement plan. Next slide. As far as the Joint Commission standards go, there are 5 categories, and these again are common across the different service lines. They involve program management, which is really the business set of standards, and by that I mean it has to do with building the team and the leadership of the team and ensuring that it's interdisciplinary and collaborative. There's the second set of standards on delivering and facilitating clinical care, which again is very much dependent on the clinical practice guidelines that you have identified and how you build processes and protocols around those. The supporting self-management set of guidelines, definitely one of the most critical, and that has to do with educating the patient and involving them in the choices about their care, as well in understanding their recovery and how to support that. Clinical information management primarily has to do with collecting and gathering the data that is necessary and making sure that it is where it needs to be, when it needs to be there. And this is very much about electronic health records, different logs that you might manage, as well as other documentation that is key to supporting the treatment that was performed. Finally, the category of performance improvement and measurement is what we touched on for a moment in the previous slide. Again, that is building a proactive performance improvement arena rather than reactive. Next slide. So once these elements are in place, that's the heart of the certification. The on-site review is the tangible experience. And our on-site reviews are every 2 years, and that is the same as with our other certifications in the stroke world, in orthopedics, perinatal, and so on. For the heart attack centers, it will be one reviewer, and they will be there for 1 day. They do quite a bit of homework before they come, but when they're there, that's 1 day. It's an efficient experience, very interactive, and they're just looking for consistent application of the standards as well as the clinical practice guidelines you follow. The Comprehensive Cardiac Center, we actually send 2 reviewers for 2 days, and again, that's because of all the service lines that are involved. One thing I want to point out about the on-site review is it is something where you identify the ready date when you tell us when you'll be ready for the on-site review to take place. I'll show you more about that in the upcoming slide. One thing you want to know is that you do receive a full 30 days advance notice of the on-site review, and that way it's not a surprise. Next slide. So let's talk a little bit about the certification cycle itself so you know what the timelines look like. It starts with the application itself. Go ahead and click Next. When you apply, you'll identify a ready date, and that's the earliest that we would come to an on-site review. We'll schedule as close to that date as possible. We ask that it be at least 4 to 6 months after you apply, if at all possible, and that allows us to have a realistic time frame to accomplish that. Again, you will receive 30 days notice prior to the on-site review taking place. At the end of the on-site review, there's a closing conference. If there are no requests for improvement or required requests for improvement, then you will be certified by the end of the on-site review. Click Next. In the event that there are some findings we'd like you to resolve, the reviewer will give you a list of those, and then they will talk to you exactly about how to document that they've been resolved. They then give you a time period of 60 days to resolve that, at which time they will go ahead and finalize the certification for your hospital. They will backdate the certification to the date of the on-site review. Go ahead and click Next. But from a timing perspective, because we ask that the ready date be 4 to 6 months after you apply, and because there is the potential of a 60-day RFI window, in your minds, you just want to plan on 6 to 8 months between the date of application to the date of finalizing the certification. Click Next. And from there, 1 year, after your 1-year anniversary, we will hold a intra-cycle call where we go over your performance metrics, your performance improvement plan, and you also update us on any changes to the program structurally. And then in the 2-year anniversary, that's when we will come back out to visit again, and that is the process over time. Next slide. The application process, I've outlined it here. The primary thing is you're going to want to connect with your associate director at Joint Commission. There are 4 of us, and we split the country up 4 ways. I am your associate director in the state of Arkansas, and we will walk you through this entire process. The application process itself is fairly simple, as long as you're going through it with a chaperone like myself or one of the other associate directors. It's pretty simple. The pre-application involves reviewing our standards and doing a gap analysis, reviewing the standardized performance measures, but you're already very familiar with those. The 3 main pieces of homework will just be to identify the clinical practice guidelines you follow, which is going to be an easy piece of homework for you all because you already know what those are. You'll also draft the performance improvement plan, and that again is something that I will help you with. Finally, you'll establish a ready date. We'll complete the application on the Connect portal together. An important thing about submitting that application is that you do not upload any performance measured data when you apply. And the main reason why is we're not looking for certain, we don't require certain scores on different measures in order for you to qualify for a certification. It is much more that you're tracking those and have identified performance improvement plans wherever there might be an opportunity to improve. For that reason, when you apply, you don't need to bring the data and we don't need to enter it into the Connect portal. You will prepare for the on-site review after you apply. I have a review process guide I'll provide you, tells you exactly how to prepare. And during, before the on-site review, that's when we'll have you upload the most recent 4 months of data on the performance measures that you've been collecting in the registry. Next slide. And that is an introduction to these programs. So I will just hand it back off to you, Kristen, and we'll go from there.
Okay, I stopped sharing the screen for just a moment, but I'm going to pull up how to come off mute for those of you that have questions. If you will just hit *6 to come off mute, and you can ask questions about Get With the Guidelines CAD, or for Zach with the PHAC and AHAR certifications. And I will check the chat box too. If anyone has any questions, they can just hit *6 to come off mute. Zach, there is one question in the chat box. If you are not accredited with TJC, can you still qualify for the PHAC certification?
Thanks, Kristen. Yes, you definitely can. The important thing is that you have been deemed as meeting the conditions of participation for CMS.
Okay, if we have any more questions, you can type them in the Q&A box, or you can hit *6 to come off mute. Okay, we have another question for you. Zach, we are accredited with ACC. Can the MI data transfer to them?
Hi. That's a great question. That's something I think that would be more of a registry question. Kristen, would you be able to shed some light on that process?
Okay. Cher, if you are using the chest pain MI registry, if you are entering directly into chest pain MI yourself, not using a third-party vendor, then you would be able to pull a file from the chest pain MI registry and email it, and we would upload it into Get With the Guidelines CAD for you. Did that answer your question? If you use a third-party vendor like Cedaron, Lumetics, then they would be the ones to send you the file to upload into Get With the Guidelines CAD. But for those of you that are entering directly into chest pain MI directly, then you can pull the file yourself and email it to a specific email address, and we would have it uploaded for you into Get With the Guidelines CAD. Okay, and we have another question. How many of the lists are pre-built, such as the med list? So the first portion of the demo before I got to the custom list, that was all pre-built. You would not have to build any medications list other than what is already there. I think we're probably talking about when I showed the statin drugs. They are looking for specific statins, so those are pre-built. You would not be adding anything other than what's already there. So as far as aspirin, the only thing that populates with that would be the dose and the frequency. Beta blocker did not ask for which one or the dose. So I think we're probably talking about like the statin. Some of them do have a pre-populated list, and but that you just choose from what is there. Okay, the next question. I was disconnected for a minute. Were you talking about being able to download information from NCDR, chest pain and MI? Yes. If you enter directly into NCDR yourself, then you can pull a file from there and email it to a specific email address, and we would upload it into Get With The Guidelines CAD for you. If you're using a third-party vendor like Lumedix or Cedar-Ron, then they would provide you with a file that you could upload into Get With The Guidelines CAD. Okay, the next question, does the tool use skip pattern logics? We call it hide show feature. So it hides the elements that do not apply to you based on the answer that you've given, or it shows them. That's probably the same thing as skip pattern. I've just never heard it called that before. So if you answer yes to something, it's going to open up more questions. If you answer no, then it will hide certain things. For instance, if you say this patient with a walk-in, it's going to make all of the EMS elements go away. And if you say that it did arrive by EMS, then those will all show up. Okay. Let's see. Is there training as to how to build our local EMS drop-down list, MD list, interventional list? Yes, absolutely. There is a tab. I think there's a training video in there, but if not, I can show you how, or I can send you step-by-step instructions. As far as the EMS list, you just go and you search by name, and then you add them. You could do, if it's a brand new agency, you could set a start date for when you want that EMS agency available, or if they've left your area, you can do an end date as well, or you can just leave it open. The MD list, they are, you can search them by the MPI number, and I believe the hospital list, if you're receiving from other agencies or transferring out, I believe that is searched by the American Hospital Association number. But absolutely, we could train you on how to do that. Is there a certain amount of time that we would have to use Get With The Guidelines CAD prior to certification? And Zach, my guess would be 4 months, but I'm going to let you answer that one.
That is correct. At the time of the on-site review, we're just going to need to see the most recent 4 months of data on the measures that you submit to the Get With The Guidelines registry. Realistically, that basically means you want to have been participating for 5 months so you can generate the 4 months of reports. Even though I believe, are those reports real time, Kristen?
They are near real time. As you could see, whenever I switched over from entering the patient into the reporting function, that patient was already available. So we call it near real time. It's almost immediate.
That's fantastic. Yep. So again, you'd probably want to be participating 4 or 5 months just so you can ensure that you have a full 4 months that you can provide during the on-site review.
And with having to wait 4 to 6 months for a site visit, you could probably, time that to where you start Get With The Guidelines CAD and apply as well. They just need the 4 months once you come for the site visit, correct?
Correct.
Okay. Let me scroll back up and see if there's any more questions. I don't see any more questions, but until we have some more, I'm just going to share my screen again and show real quick how to, well, okay, hang on just a second. How to build those custom lists. So you should be able to see my screen. I'm on the community page again. And for those of you that asked about uploading, if you're able to pull the file from NCDR yourself, then we would do the upload. If you're using a third-party vendor, then you would click on the upload button and you would just drop your file right here and upload it. Form management is where you would create your custom list. Click on that, and then you can select EMS. We want to, since this is a demo site, we have them from all over the nation in here, but you can create a new one. I'm trying to think if there's two we might not possibly have in here for Arkansas. But you would just search them. Let's see. And so here I found Crossett Fire Department, Crossett, Arkansas. So I would select them. I could do a start date if they were brand new, or maybe this agency was no more and we wanted to do an end date so they're no longer in my drop-down list, then I could do either of those dates, but I just want to leave it open-ended. So I've selected the fire department, and I'm going to do save and exit. So the next time I go in, they'll be available for me to select from that list. Same thing for ED physicians, NPI, or the physician interventionalist. If we want to create a new one, if you have the NPI number, that would be the route to go there. And I do not have one off the top of my head, but you would just enter that and then do a search for that. It's possible we could search by name. Let me see if it will allow me. No, it is asking for an NPI number. And so if you want to do an advanced search, if you're having trouble finding it, then there are some more options to help you add a physician there. And then we'll go back in there one more time. So you can manage your own attending physician list, ED physician, EMS agency, hospitals as well. There is the custom fields. Here's where you go to create or to edit the ones, like we were just showing how simple it was. Somebody did eye color and they did a single select with a drop-down menu. But you could choose date, multi-select, check box. There's quite a few options, but you just do create a new one, and you save it the same way there. We do have a notifications area as well, where IQVIA lets you know if they're going to be closed. If you need technical support, they were closed July 4th and 5th. They let you know when there's going to be system maintenance, or when we add or make any changes. That's in there as well. I'm going to show you the coding instructions real quick. There's something specific you want to look at, like the entry criteria, click on that and it takes you directly there. If anything is highlighted, then you know that there's been some changes made, and it will show you any changes highlighted until they update again. So the last updates to the coding instructions were let me take it to the top. May. Those were back in May. Here's the blank form, which we should have the short version of the referral center form come out later this month, and it should be only 2 pages long. So anything you say in bold is required, and I will say that most of the data elements are required because it's the data has been trimmed, it's been streamlined to where we're not capturing a lot of extra data elements. So, and the same here. Anytime that there's been a change, it will be highlighted in yellow to let you know the changes. Oh, somebody said try LikeNet. Okay. Do we have any more questions? Anything else that you want to see in the registry? I know I was trying to stick to my 30 minutes, and I didn't do a whole lot on reporting. We could go back and run some reports. There's something specific that you're wanting there. For those of you that had trouble with the audio in the beginning, I did record this today, and I will share this with you. If you need any one-on-one demos or have any questions for myself or Zach with the Joint Commission on the certifications, we can arrange that as well. If there's somebody else at your facility that needs to have this information, just reach out to us and let us know. And if there are no more questions, we'll go ahead and end today. You guys have a great day, and thank you for joining.
Thank you.
Thanks, Zach.